So headache is a very, very common complaint in a primary care physician's office. We're going to, with this presentation, teach you a whole bunch about the migrainous process. Any that are dealing with headaches or have family members dealing with them, what's typical is that there's this laundry list, if not longer, of types of headaches. And we try to categorize, or convention tries to categorize a person into that, and then ultimately you're just using some medication typically to offset that. We feel that we should be doing better. We should be looking at lifestyle, because in many instances, not all, in many instances, it is a lifestyle of too many triggers towards headache for that individual, and a lower threshold to those problems creates the headache. So when we can identify and then start to take action, it doesn't mean that it's easy, but start to take action by minimizing triggers, helping with our raising our threshold, we can start to offset, reduce our frequency, intensity, severity, which means many times less medication and greater function, better life. Most headaches, even if they're really bad, are benign and treatable, or manageable is the word I usually like to use, better than treatable. Treatable kind of connotates we're done with that. Okay? When the reality is most health problems we manage, meaning that if we stop doing the things that are necessary, what happens? They come back, whether it's high cholesterol or high blood pressure or diabetes or even arthritis. You stop doing the things that are necessary to stay well with that problem, manage that problem, and they usually rear their ugly head, sometimes very quickly. A good consultation examination is very important. Many people, when they have pain, especially in the past decade, when you listen to, watch sports, everybody wants to run and get what? Diagnostically. An MRI. See what's going on. If I can see it, then that means, we know the problem. And it's not the case many times at all. Sometimes images on an MRI are incidental. Sometimes people have really bad, painful, and functional problems, and there's nothing on an MRI. We don't always get a true picture. Sometimes the person, let's take a back problem, has a back problem. You do the MRI, there is a finding, but it doesn't correlate with the back problem. It doesn't make any anatomical or functional sense. So it's not always the answer, but sometimes they are necessary. Usually that's when we're suspecting secondary headache that is due to something else going on in the body, a diseased process. Fortunately, a very, very, very small percentage of those headaches are caused by serious intracranial problems, which, many of us get a bad headache, what's the first thing that's coming to our mind? Okay? There's a clot or blockage, or there's something growing in there, okay, if the headache becomes real severe. Now, if we haven't had headaches and all of a sudden we are getting pretty bad headaches out of the blue and we can't put our finger on it, it does heighten our concern and create a yellow flag for us as clinicians. These account for most headaches. The thing about headaches is that most of us have had at least a headache, and a bad one, so we can relate to people who are dealing with headaches on a daily basis with minimal relief from medications. I mean, certainly I have had headaches in the past, and thank goodness, they're rare enough, so maybe if I get through a day, I can take a couple of ibuprofen, and it works. I can't imagine not being able to find a way to have it stop, okay, and have to conduct your life, children, job, family, and so forth. Headache triggers are detected by centers within the brain. We know the hypothalamus is involved, but there may be other associated centers in the brain. And these centers also control many vital processes in the body. Your sleep-wake cycle, whether you're hungry or not, hormone balance, and the autonomic nervous system part of your nervous system, which is the part that conducts things without you having to volitionally control them. Moving my arms, talking, I'm controlling that. Your heart rate, and whether your blood vessels are dilating or not, getting nauseous, are all kind of autonomic, and there's a different component to the nervous system. All come from these same centers, and it's interesting enough how many of us have problems with headache as it relates to our sleep cycle being off, staying up too late, or sleeping too long, or sleeping, different on the weekday versus the weekend, okay? Or getting hungry. We joked about skipping the meal before. Very, very real, very real. Okay? Effects of blood sugar on the centers of hunger in our brain. Hormone regulation, we all know that. Women know it probably better than men because there's more of a fluctuation through the month and how that can impact headache. But the centers in the brain are affected by the triggers, And then there are neurochemical messengers are released in response to those triggers. Okay? And they produce a number of bodily responses, but the most significant is inflammation and what's called dilatation to blood vessels. So centers of the brain coming from this nerve will, when they are triggered, send messages, and with migrainous process, more triggers, we get dilatation and inflammation of the blood vessels. Pressure, okay, is created, inflammation is created. And whatever vessels are mainly being affected is generally where you're going to start to feel pain, because now pain receptors around here are going to go back to your brain saying, wow, it hurts over there. This is the migrainous process. This is basically how a headache is created. And the more of it that you are triggering on any given day, the more of a problem, i.e. headache, you will have. And if there's so much, you may start to get ancillary symptoms, associated symptoms with that. What are some of the symptoms we associate with headache? Nauseousness, dizziness. Some people, how about sensitivity to light, smells, noise? So the idea is to minimize triggers, and also we're going to talk about something called threshold, where we want to heighten the threshold so the triggers don't go over the threshold, creating more of this process. So the IHS says 4 main types of primary headaches: migraine, tension type, cluster, medicine associated. So migraine as it stands conventionally. Many people, probably double that, left undiagnosed, more common in women. It can happen with an aura. People who have aura with migraine, which is classic migraine, know that it's coming on. Know that it's coming on. They may get visual disturbances. They may get super, super sensitive to smell or light or sound. They may start to feel a little nauseous already and then get a little anxious because they know that it's coming on. Aura. Visual and auditory disturbances can happen, usually several minutes or a little bit longer. Classic migraine, which is the less common. Most people that are experiencing real or true categorically migraines don't have that. Severe headache, usually lasting several hours or more. It's usually one side and pulsating, and it can be aggravated by minimal exertion. Tension type, muscle contraction headache. Many people that have this know that they have jaw stress, they clench, and maybe it's through here. They have so much neck tension, and it starts to come up from this area. So we start to call that tension hype, when we are starting to look at it more like that tension is a threshold lowering activity, if you will, in the body, or situation in the body. So now the triggers that are accumulating on any given day are easy enough to create a headache. It just happens to feel it there because there's already a lot of tension. This is a very common one because in the past couple decades, I guess, certainly more prevalent in the last 10 to 15, we do a lot of sitting at computers when we work. And the head is doing what? Are we sitting up like this at our computers? No, we're just, okay. I teach this stuff on a daily basis, and if I have to sit in front of the computer, I find myself doing the same thing. I'm like, what in the world am I doing? You know, I teach this stuff. So back here, but we don't do that. And this stress creates all this tension, and it goes way down deep right into the neck and the discs of the spine. And over time, that stress, the wearing of discs, the chronic tension on muscles, is just a lower threshold for you to have on any given day a little bit more emotional stress tied in with the barometric pressure, and you ate some chocolate, boom, you got a headache. Generally consider the tension type to be of more mild or moderate variety. Again, remember now, I said this is more convention. Our opinion is it's just a degree of how far you've gone into the migrainous process. How many have heard of cluster headaches? I think they're quite rare, at least doing this work for almost 30 years now. But I have had several patients. It's very interesting how this comes on.